All right, so without further ado, let's get started. Thank you so much, everyone, for joining us today. We're very happy and pleased to get our day 2 of Global Digital Health Summit started. My name is Asma Rayani. I'm a second-year Master of Science student in the Department of Epidemiology with a focus on cardiovascular disease and clinical epidemiology. In addition to my role as a student here, I also serve as a Director of Education and Digital Health Society, as well as Community Service Chair for Johns Hopkins Graduate Muslim Student Association, and additionally as Curriculum Committee Representative for Epidemiology Student Organization. And I would now request my co-moderator to introduce himself.
Good morning, everyone. I'm Rishikesh Satyamurthy. I'm a first-year student in the Master of Science in Epidemiology program with a focus on cancer epidemiology. In addition to that, I am the Director of Asian American Liaison for the Asia Pacific Public Health Network and co-director of events for the One Health student group. Before we get started with the introductions, I want to mention that these introductions are merely the highlights of their career. In reality, they have accomplished a lot more.
Very well said. I would now like to introduce Dr. Asad Mia. Dr. Mia is a professor and former chair, Department of Emergency Medicine at the Aga Khan University. He also founded and led the Critical Creative Innovative Thinking Forum, CCIT, an ideation, innovation, business incubation hub for healthcare and else at AKU for a decade. Beyond his roles as an ER physician, researcher, and innovator entrepreneur, Dr. Mia has a deep passion for writing, exploring topics ranging from healthcare and education to innovation, children, humor, and popular culture. Dr. Mia has become a strong advocate for healthcare workforces' well-being through burnout mitigation. For this, he coaches through innovative fitness regimens, and we're very excited to have Dr. Mia with us today.
Now, it is my pleasure to invite Dr. Asad Latif. So Dr. Latif is currently the chair of the Department of Anesthesiology at the Aga Khan University, Karachi, Pakistan. He's a graduate of the AKU Medical College and also did an internship in general surgery from the Hospital of St. Raphael, New Haven, Connecticut, and completed a residency in anesthesiology at the Beth Israel Medical Center in Boston, Massachusetts. He finished his residency from SUNY New York at Brooklyn, and then did a fellowship in adult clinical care medicine from the Johns Hopkins School of Medicine. Dr. Latif joined the faculty at the Department of Anesthesiology at Hopkins, following which he did a public health training focusing on health systems and international health from Bloomberg. Aside from his active clinical responsibilities, Dr. Latif's research interests lie in patient safety, quality improvement, utility of telemedicine in intensive care units, with an emphasis on global surgical care, prevention of obstetric emergencies, hospital-acquired infections, and health system strengthening, particularly in developing countries. We are really happy to have Dr. Latif here. I'd then like to introduce Dr. Chris Ford. Dr. Ford is the founder and director of the Telebehavioral Health Center of Excellence in the Indian Health Service, HIS, which is an agency at the United States Department of Human and Health Services. He's a member of the Choctaw Nation of Oklahoma. He received his doctorate in child clinical psychology from the Oklahoma State University. He practiced psychology at the ACL Service Unit for 10 years, serving multiple tribes and communities in New Mexico. After a brief time away from the HIS, as a forensic psychologist, Dr. Ford served as the HIS Albuquerque area behavioral health consultant from 2008 to 2016. In 2010, Dr. Ford was awarded funding via the Methamphetamine Suicide Prevention Initiative to establish the HIS Telebehavioral Health Center of Excellence. The mandate of the center is to explore the feasibility of telebehavioral health within HIS, improve access to care, develop models of care, and to address sustainability. In 2016, Dr. Ford accepted a position with the HIS Headquarters Division of Behavioral Health as the director of the Telebehavioral Health Center of Excellence. We're really happy to have Dr. Ford here.
And now it is my honor to introduce Dr. Surajit Nandi. Dr. Nandi, an alumnus of esteemed institutions such as Harvard, Duke, and Washington universities, has a background that combines clinical medicine, computational neuroscience, and public health. After completing his residency at the Massachusetts General Hospital of Harvard Medical School, Dr. Nandi earned his PhD in computational neuroscience and furthered his expertise with a degree in public health. His journey is marked by a dedication to improving health for all, a commitment that led him to return to India to address the massive healthcare needs of both rural and urban populations. Recognizing the potential of artificial intelligence to revolutionize healthcare, Dr. Nandi founded Raxa in 2011. His innovative approach at Raxa harnesses the power of AI to deliver expert, trusted, and accessible healthcare. Under his leadership, Raxa has developed AI-based systems that enhance the quality of care at the point of service. These groundbreaking systems not only empower the platform Raxa offers, but also symbolize Dr. Nandi's dedication to making quality healthcare a reality for everyone. So thank you so much, Dr. Nandi, for joining us today.
Thank you.
So with all the introductions, it would be great for us if we can get started with the questions. So the first question that we would like to ask, and that would be for everyone in the panel, is that we have a diverse student body here at Hopkins with varying degrees of expertise in digital health. So to start us off, could you share in a few words, as a healthcare professional, what does your work in the digital health space looks like? Would Dr. Mia like to go ahead first?
Yes, hi. Thank you for the question, and hello, everyone. It's a great honor to be here. Can you hear me?
Yes, we can.
Oh, okay, all right. So yeah, just FYI, in case there's some disruption in the signal over here, there might be a bit of a pause. Just bear with me. So the question is my experience, particularly with students in the digital health space. So as an ER physician, I've done things that are not, I wouldn't consider them to be very traditionally digital health based. I've done things through the innovation, creativity, and entrepreneurship framework. And as this summit progresses or this panel discussion progresses, I'll get more into that, hopefully. But interestingly, by working with students of healthcare, so healthcare professional professional students, which would be medical students and nursing students predominantly, we've got them into cross-disciplinary platforms such as hackathons. And in fact, that would be the example that I would have given to you as well in terms of what platform we've kind of implemented at AKU in Karachi that has led to new ideas, especially where students are concerned. So through these platforms, through these interdisciplinary hackathons, a lot of team-based ideas have come to the forefront, which are digital health-based. So whether those would be considered mobile health, mHealth apps, or really simple, straightforward platforms of electronic health records. I'm not talking about like huge platforms such as Epic, but student-led teams that have looked at what would work for a rural hospital, for example, right, or a rural clinic. And so those kinds of things, I would say. And then point of care testing has come up as well through digital health approaches. In the emergency department, very simple, straightforward assays, biochemical assays, nothing fancy. All that will require is a bedside test, for example, right? And then other than all of these things, I would say a lot of process-based innovations have also come through, and those would be considered under the realm of digital health. I hope that helps to get started.
Yes, it does. Thank you so much. Thank you. Dr. Fo, would you like to go next?
I'd be happy to. Again, I appreciate the honor of presenting with all these wonderful and accomplished folks on this panel. For us in the Indian Health Service, there are a couple of things. It is kind of a tough balance running a national program where we have sites literally coast to coast, border to border across the US, but also having to drill down to the direct patient care level. That is really our mission, is getting access to areas that don't have it, especially with specialty care. A lot of child-based services are difficult for our sites to recruit and retain those types of providers. So it really is this balancing act to have this overarching approach, but be able to get down to that level where we can really impact patients' lives and communities' lives. So that's what we do on this daily basis, is that balancing and trying to make sure we're seeing the patients, but also have infrastructure and policy in place that supports the entire country. So that is our struggle daily back and forth, but I think that we've been able to do that pretty well and have an impact as far as access to care goes for the American Indian and the Native Alaska population within the US. Thanks.
Thank you so much, Dr. Four. Would Dr. Nandi like to go ahead next? And feel free to share your slides, and if that helps this question. Dr. Nandi, we can't hear you.
If you could unmute yourself.
Hi. Sorry, can you hear
We
me?
can hear you now. Yes.
Yeah.
Great. And you can see my screen. So I just like to maybe. So the question was, what do we do all day? And I think the main question that we try and answer is the answer to this graph. This data is not really available anyway, so I took the liberty of choosing the smartest person or entity that I knew to do it. So I asked ChatGPT, which is, I asked him to make a graph over the past 10 years of car maintenance app usage, social media app usage, and health app usage. And in so doing, making a positive and a negative control of digital health. And as you can see, this is ChatGPT's estimate of what these things have done over the last 10 years. The users in social media apps have gone up, whereas the users in car maintenance apps have remained largely stable, they've gone up a little bit, as has the users in health apps. And really the question is why is that the case? Because I see that your conference is based on the idea that digital health is a good thing. Well, if it is such a good thing, then why is this graph the case? Let me ask you all a question, those of you in the audience. How many of you have used a social media app in the last year? By applause, could you indicate how many of you have used a social media app in the last year? Okay, and
Everyone in the room
let's
has
make it more. Okay, how many people have used a social media app in the last day? Again? Okay, how many of you have used a car maintenance app in the last day? Okay,
No claps.
and how many of you have used a health app in the last day? Wow, I'm surprised. The answer in most populations would be about, very little. Oh, I guess there's not that many of you, but very few people have occasion to use digital health. And the question is why? And so we spend our time trying to answer this question. The reason why people don't, and you could say that this is, the chicken or the egg, that in the OECD, health is amongst the least invested of all the sectors for ICT as well as software and databases. Before we talk about digital health and why digital health is such a universally good thing, I think we have to deal with those two issues. Number one, people don't want to use digital health. And number two, as a result, there's not much investment in it. So my job, our job is actually trying to change both of those issues. I'm suggesting that one of the best ways to perhaps do that is to change it from digital health and make the focus of your conference perhaps digital life, because everything matters. So I'll stop there and take further questions later. Thanks.
Thank you so much. That's a very interesting perspective. I would now like to request Dr. Latif to not only share a few words as a healthcare professional, what does your work in the digital health space look like, but I would also like him to talk a bit about the tele-COVID ICU. I had the honor to experience and sort of witness some of the work that was being done in Pakistan while I was there. And I would really like him to share it with the audience today as to how this entire system worked through the pandemic and how can that be integrated into healthcare systems post-pandemic. Thank you, Dr. Latif.
All right. Thank you, Asma. And thank you to your panel for this kind of invitation. So I think, like many of my colleagues, I'm a clinician who's had the occasion to use telehealth in many ways. My relationship started maybe over a decade ago when we tried to bring telecritical care to Johns Hopkins, and to be honest, failed. And then with a health app startup, maybe 8 years ago, which we ultimately wound up and sold to Massimo. And then using that background, when I moved to Pakistan about 5 years ago, the COVID pandemic happened. And one of the things that was obvious was the need for expertise that wasn't necessarily available everywhere. And we ended up using a mHealth sort of approach to leverage limited resources. In this case, it was people with training in critical care for need that was now global, right? For example, in Karachi, in Pakistan, we had about 45 ventilators in the public sector in the province of Sindh. Sounds like a small number. It's even smaller when you realize the province of Sindh is bigger than most states. It's about 60 plus million people. That increased almost overnight tenfold to over 450 or 500 ventilators. But the workforce didn't. The expertise to run 40 wasn't there before, and now we had to run over 500 in just one province. This tenfold increase happening across the country. So we realized mHealth has many uses, and often we focus on the fancy uses like apps and stuff, and those fancy interfaces. But what we focused on is the most basic aspect, which is using it to leverage limited expertise to many areas, so kind of a hub and spoke model. Our adventure started with me trying to implement something akin to what we had in the US, which is telerounding with true audio-visual, live telemetry feeds, kind of looking at patients in real time. And we quickly realized that the infrastructure for data transfer wasn't really there in terms of connectivity. And even in the place where it wasn't, turns out one of the earlier lessons that I learned in our startup still applied, which is it's very hard to get physicians and healthcare providers to change their behavior. So getting them to change their behavior in terms of telerounding and turning on their computer, you give them technology, you give them the Wi-Fi, but getting them to turn on something and round with a cow, a computer on wheels or a robot, the virtual presence was very difficult because they felt like it was tedious, it was oversight, it was something they're not used to, they didn't understand. So it quickly devolved into very simple sort of mechanism, what's acceptable, which was sharing information over social media. So the media platforms like WhatsApp and stuff, in which people felt more comfortable sending information, talking on the phone, talking the video chat was still limited, but it would happen with the younger people. With telehealth in Pakistan, we realized people, the main hurdle to this is often people. It's not necessarily technology. It's not necessarily the approach or the connectivity. It's often getting people to change their behavior and use it. I think Dr. Nandi earlier mentioned a fantastic slide about social media and somehow it's gained acceptance worldwide, and it's been increasing steadily at an almost logarithmic pace algorithmic pace over the last decade. That hasn't happened for healthcare, and I think that's partially because of perception. We did great work in COVID with leveraging our limited expertise of intensivists, which was about, I think there's 30 that have been trained in Pakistan officially, according to government stats, of which only, I think, 3/4 or 2/3 were out of the country. But leveraging that to help thousands of patients, and we were able to do that by having these virtual rounds and what developed to basic using widely available apps like Zoom and WhatsApp to exchange information and then confirm that and do that back. So I think our experiences with telehealth have really made me aware that it's different. Contexts matter. It's not just about the connectivity, it's about the context, and people's relationship with technology matters also. Fortunately, we've seen a significant shift over the last 3 years, significantly, in terms of acceptance of telerounding. I mean, before we couldn't even get teleconsultations or clinic visits because people just want to see a flesh and blood doctor, especially in LMIC settings or the Eastern world, right? In the Middle East and Pakistani culture and stuff. But COVID really changed that. The acceptability of technology as a day-to-day life and even for healthcare improved. We saw that shift move towards acceptance, and unfortunately, we've seen a slight shift back towards people wanting to be face-to-face with doctors again. But I'm optimistic. I think the future, we've got a lot of lessons, and with the future, we will be able to overcome some of these hurdles, especially with the younger generation like you guys, who are much more comfortable with technology.
Thank you, Dr. Latif. And I think that's very well said. Context matters, and people's relationship with technology is something that's very important to consider and to be taken into account. Thank you.
So our next question is to Dr. Mia. Dr. Mia, could you be able to discuss the intersection between healthcare, entrepreneurship, and innovation, particularly in the context of developing sustainable solutions in low-resource settings?
That's a great question. Thank you for that. But it's a very loaded question, and it's a very packed question as well, right? So I'll try my best to kind of like unpack it somewhat. So first of all, the question that you asked was focusing on, or focuses me on, healthcare, entrepreneurship, and innovation. My experience in an LMIC setting, just wanted to like let the audience know that prior to moving back to Pakistan, I was in the US for 15 years, where I trained and then I practiced in Houston at Baylor College of Medicine and Texas Children's Hospital. So I think my story kind of starts over there, because moving from the US to Pakistan, and then the challenges of being faced with like all kinds of like shortage of everything pretty much, right? So resources, whether it's capital resource or it's human resource, technology. So working within the limitations, although the Arkan University in Karachi, you could consider that to be pretty well equipped in terms of medical technology, diagnostics, and so on. However, if I think about innovation and entrepreneurship, my experience working in Pakistan has kind of guided me towards considering innovation to be on a spectrum, and entrepreneurship is there, but also creativity. So that's one point I'd like to make over here, that think about innovation along with creativity and entrepreneurship, whether one is implemented before any other, doesn't matter. I mean, we've kind of studied and written about these things as well, and if anybody's interested, then you can just reach out, particularly from a sustainability perspective. So you asked me about this from a sustainability perspective for LMICs. All of these things, whether it's you're looking at healthcare innovation or healthcare creativity or healthcare entrepreneurship, it really starts, in my opinion, with the healthcare needs of the population that you're serving. So we always do start off with somewhat of a gap analysis or a feasibility. Okay, what what are the needs, and contextualizing it to the setting. Something from the US is not just going to be a cookie cutter, copy paste approach for Pakistan. It doesn't work. It's been tried multiple times. It does not work. So that's been another realization or learning, that starting off with your own population, what is the population's needs, and contextualizing your innovation, creativity, and entrepreneurship makes it exceedingly important. And so from a sustainability perspective as well, keeping in mind that Pakistan or other LMICs, whether it's India, Bangladesh, Sri Lanka, or Africa for that matter, East Africa, because Arkan University also has campuses in East Africa. So considering these to be emerging markets, right? So that's a huge opportunity. It's a huge challenge as well, but it's a huge opportunity. So keeping in mind, because from the entrepreneurship perspective, that these are emerging markets, and that's a great potential to be tapped into. And then all the challenges that come with dealing with emerging markets. Jugaad innovation. I don't know whether people in the audience are familiar with, definitely people from South Asia, from India, from Pakistan, and Bangladesh, Sri Lanka even, are very familiar with Jugaad. Jugaad is a fast-tracked approach to innovation. Jugaad innovation focuses you on quick cycles of innovation. And so you cut down on your costs. So it's cheap, it's fast, and it's easy. And so you can rapidly prototype and experiment. So that's the other point, rapid prototyping and experimentation cycles. So Jugaad innovation, frugal innovation is another way of looking at that. And then rapid prototyping, testing, experimentation, iterating on that. One last point I would make over here is just keeping in mind that failing, it's okay. And fast failing or failing and pivoting, that's been another important lesson that we've learned along the way, where sustaining some of these processes have been concerned. Thanks.
Thank you for such a good answer. And Jugaad is kind of our favorite word growing up in the subcontinent, so we all relate to that. Thank you so much for that.
And we see many people smiling in the audience, so they very much agree with that. Thank you, Dr. Mia. Dr. Four, I will now pose two questions to you. One is, how does the Telebehavioral Health Center of Excellence train and prepare healthcare providers for the unique aspects of delivering care via telehealth, and especially if you can speak in the context of tribal communities? And then, what technologies have proven most effective in engaging patients? Thank you.
Great. Thank you. Those are some great questions. So I think just take a very quick step back. You may or may not know that within the United States, there are 574 federally recognized tribes in this country. That is more federally recognized sovereign nations than there are countries in the world. So they are extremely diverse. We lump them all together oftentimes as Indians and Americans, whatever term, but they're extremely diverse. And so for us, whenever we go into a community, we really work very closely with that community to figure out kind of what was previously mentioned. What are the gaps in care? What do they need? But then also, what are their cultural beliefs? Because the beliefs between any single tribe and what I would call the mainstream culture in the US, that difference is probably less than the difference between tribes. You have tribes that critical things, how you treat birth, how you treat death, your beliefs around healthcare, whether there is often intertwined with culture and spiritual beliefs, especially around behavioral health issues. You know, a family may say, you know, this individual put some sort of hex on me or cursed me because of an old family conflict. And so, you know, you have to think outside of the Western medicine box in dealing with our tribal partners. And so for us, the way we do that, we treat each of them as a unique entity, and we go in and talk with them. We have a virtual meet and greet with community members and staff at the facilities to make sure our provider, though they may be hundreds of miles away get some context within which they're seeing those patients. So I think that's really important. Another thing that's been key for us is that we have been able to hire a lot of American Indian Native Alaskan practitioners. And so, they come in with a baseline level of knowledge that's pretty amazing and can go into those communities and be effective. Now, that doesn't mean if you're not Native that you can't work in Native communities, but I think it does give them a sort of a leg up, a head start, if you will, on being able to provide those services. So that's one thing we do. We really try to integrate and focus the program and adapt the program to the community needs, their beliefs, their cultures. We also do consultation. We have some mentoring that goes on with folks in the community, with our providers, and then providers who've been doing this longer, especially who are Native, they may have a better sense of how to approach things, and so they can mentor other providers that we use. As far as technology goes, our technology within the federal government system, we're pretty limited on this, especially with the public health emergency winding down. During the public health emergency, we could use almost any platform, but now that is ended, so we're back into having to be compliant with HIPAA, the Privacy Act, and all sorts of other things that really ensure that our connections are very secure. So currently we use WebEx is one of our key platforms. It is something that we host internally, and it is totally secure and HIPAA compliant. That allows us to reach into our facilities and do clinic-based care. However, during the pandemic, we found that it did not fare as well whenever we were trying to reach into patients' homes or into the communities directly. So we now have a second platform, AA Ring MD. And so that's allowed us to really expand care outside of the four walls of our facilities when needed, touching patients in their homes, chapter houses, libraries, schools, settings like that. So we try to use a combination of settings depending on the type of services, whether it's a clinic-based service that we're doing or whether it's a home-based, community-based service that we're doing. So having those options has allowed us, again, to reach more folks than we could previously, but I think there's still some work to do, as mentioned before, around connectivity. In the patient and the communities we serve, connectivity is also a significant issue. And frankly, a lot of the services that we do are audio only because we can't get the televideo connection going. Thanks.
Thank you, Dr. Farr. And I just want to connect the dots here. What Dr. Latif said earlier, context matters, and what you just said about unique entities, so treating each tribe as a unique entity within itself. It's just so great that we have, a similar perspective, but from two different parts of the world. So which just goes to show that medicine is really global, but at the same time, so similar.
Yeah. So the next two-part question would be to Dr. Nandi. So the first part is, in the context of using advanced technologies like AI, especially in healthcare, how can we ensure that ethical medical practices are being taken care of, and how does it protect patient rights? And the second part of the question is, what emerging technologies do you believe will have the most significant impact on the future of healthcare delivery?
Wow. Tough questions to answer. So the answer to the first question is, I think you cannot ensure that ethical medical practice will be done through AI the same way that you cannot ensure that ethical medical practice can be done by humans. All you can do is have certain boundaries during, the practice of this medical care, and if anyone strays past the boundaries, there should be appropriate accountability. So the idea that there can and should be ethical medical practice is actually, I'd like you to, as students, unpack the question. You're trying to say that, every tool that I use should be perfect. And a power structure is created by the tool user and the tool. The tool must be perfect, but the tool user can be to err as human, right? The Institute of Medicine report for healthcare errors. So if now human decision making is replaced to some extent, or enhanced by AI, I think it's reasonable to presume that what will happen is that you will get things that are up against what we think of ethical is ethical right now, but that will also change over time. The ethics of AI and medical practice will change as AI becomes more and more ubiquitous. And remind me what the second question was.
Yeah, so the second question was, what emerging technologies do you believe will have the most significant impact on healthcare delivery? The future, perhaps.
Right. I'm reluctant to do this, but I will actually bore you with just one more slide. And this slide is again, a somewhat, this is the supply problem of non-digital health, right? And what's denoted here is the ratio of patients to doctors across the world. And as you can see in the country that you are in right now, it's about 390 to 1. In India, where I am right now, 1700 to 1. Others in Pakistan are slightly better off. But there are countries in sub-Saharan Africa which are 50,000 to 1. This is, again, to certified physicians. Whereas, Cuba, for example, is 170 to 1. So there's a whole range of, the access to sort of to a human healthcare provider. Now, all this costs a lot. So in India, it costs about rupees 198 lakhs to 1.7 crores. That's about $250,000 per healthcare provider. And the shortfall, therefore, is about 15 billion. It's much more than that. It's $1.5 trillion to have enough people to solve every single person's health issues in India. India doesn't have that money. Most countries in the global south don't. In fact, in places like the US and the OECD, and you have Dr. Four, who is the leader of such services, one of the challenges is ensuring that the distribution of healthcare providers actually goes to where the diseases are. So this is a major need that is going to be replaced and really met by AI, because the AI is one thing that you can get into the areas, at least in an informational sense rather than in a physical sense, where the diseases are and where the need is. And so I think that decision making at the edge is something that we're going to see a lot of change in, and that's going to happen much sooner than one would expect.
Thank you so much. That's such a statistically backed answer, and we are really happy to see that.
Thank you. And now, Dr. Lateef, many of us who are students here are interested in learning about importance of interdisciplinary collaboration in advancing digital health. If you could also talk about how should medical education evolve to incorporate health competencies? Thank you.
Could you break the question down a bit more? So, because the first part was about interdisciplinary care and how that would benefit from digital health.
Importance
the second
of
part
interdisciplinary. Second part is how should medical education evolve to incorporate digital health competencies?
Okay, so I'll actually answer the second part of the question first, because I think we're already seeing that transition happen, right? With digital health being incorporated into medical care, into medical education. And I think COVID forced us to do that almost overnight when hospitals and medical colleges shut down. In fact, students were learning from home, and this was happening across the board from elementary schools through medical schools. And I think you guys were also, I know you as well, were probably impacted by this personally also. The transition had been happening for a while in education with online learning and classes. I think Bloomberg was one of the first few places to take this on, where we have online offerings of full courses. But often the way that we were doing it in most of education was transitioning or translating what we were doing in person to online. So synchronous learning online was happening. We give lectures, and instead of having the audience in front of you in the room, we were doing stuff like we're doing right now, in which the teacher would give a lecture online live, and everybody would listen, or at worst, they'd be recordings. I think COVID forced us to widen the adoption of digital digital approaches towards education. And in many cases, it was exactly what was happening in the West prior, and this happened globally, which is synchronous learning online, and forces move to that. So it forced people to move out of just the physical brick and mortar structure. But I think the next step in evolution is also start happening. It happened in places like Bloomberg in the US, and is going to be forced upon many other people, where we realize that we have to be more creative about how to teach online. But the way we teach in person is not going to work as a live lecture online, because people can turn their cameras off, multitask, do other things on different screens. But I think it's a good problem to have, because we are forced to look at that and work on that. So the change is already happening across all levels of education, and medical education has started doing that also. Where we're struggling really is probably the clinical aspects of it, right? The clinical care aspects have traditionally been a hands-on examination kind of an apprenticeship model, which we've had. And that is where I think the next stage of evolution will really happen in medicine, especially with the simulators and simulation-based approaches that we have, where we will have to figure out how we translate clinical skills and things like examination skills, procedural skills, to students in using digital health. And the kernels of that are there with SimMan 3G and those sort of simulators, very advanced simulators, which can do that. But adoption is still going to be resource dependent, and also going to be dependent on local settings and their acceptance technology. I personally think COVID has probably advanced it decades faster than it would have had happened otherwise. But the change is coming. In terms of multidisciplinary care and its role in digital health, I mean, as an intensivist, I could not believe more in multidisciplinary care, because ultimately there are many functions that are taken over by electronic platforms, right? Vital sign capture, for example. I work in ICU. We're dependent very much so on a lot of information and data that we take from the patient's bedside, a lot of physiologic data, a lot of lab data, a lot of pharmacy data that we integrate traditionally in large pieces of paper, which have all of this in one sheet as a flow sheet, and we integrate that as clinicians, and then we process it in our minds and make some sort of decision. We see trends over time. The digital platform has already started with the EMRs in the US and the meaningful use mandate that came out in the Obama administration. The US healthcare was forced to move towards digital care in various ways over the years, over the last decade or so. Epic and these larger platforms have really integrated everything in all the way from physiologic monitoring, and rather than us inputting data, which we did by hand, into the electronic system, now it's actually pulling it straight from the monitors and the various entities. So it's really changed the role of nurses, the role of clinicians, the role of pharmacists, because now that data is just being collected for them. And I think it's actually freeing up healthcare providers to do a lot more of the thinking aspects of it, right? The thinking, the reaction, the interpreting aspects, which, if Dr. Nandi is right, AI will take over in a few years anyways. But it'll be based on, I don't think we're quite there yet for the vast majority of the world. So we do need to look outside the traditional approach, right? So digital health is changing our jobs in multidisciplinary care also, where there's nurses, where there's pharmacists, where there's doctors, and automating a lot of the things that we did by hand. How is it going to change the interaction between the various healthcare team members? That remains to be seen. And I think that is where the focus for the next decade will be. We can get computers and electronic care and digital health to do automate a lot of our old functions, but then what do we do? And what value do we bring as healthcare providers beyond that? I think that is what the next decade will really focus on. And I look forward to actually being a part of understanding how that happens.
Thank you, Dr. Lateef. We still have a few questions, but we would take a pause here and hand it over to our audience in case they have any questions. All right, great. We have questions from the audience. If you could please introduce yourself and tell the program you're from, and then ask your question. Do you want to come here and do it? Yes.
Hi, I'm Maria. I'm in the MPH program studying global health. And first, I would like to appreciate the insights that Chris shared with us with his work in telehealth with indigenous populations. We actually just approved with the Ministry of Health in Brazil 2 days ago, a project in telehealth will be the first one in a national level, so I appreciate what you share. And I guess my question is that in the past, I worked with like a few years ago with physicians building startups in health tech, and my background is in computer engineering, so we are trained to make mistakes and then submit and debug. So it's part of our training. And I think in the clinical settings, the training is the opposite of making mistakes because it can like cost lives and all the mindset that is very different. So I guess my question, and it was hard to navigate that. So yeah, let's test this in a pilot in a small scale. And then the clinician's like, yeah, that not works like that. I need something more tangible. So if you could share insights on how you navigate this in like medicine and clinical, not just physicians, but also like other professionals. Thank you. It's open, but I think for, I forgot his name.
Dr. Mia?
Yeah. Thank you.
So if Dr. Mia would like to go first.
Yeah, sure. I think that was addressed to me because I mentioned about failure and failing fast, right? So I do understand. I'm an ER physician. I'm a pediatric ER physician, right? So when I say that about fast failure or failing fast and pivoting, it's not so much about obviously about clinical workspaces. I'm talking about process-based innovation, which you want to then prototype and test, and not necessarily the first thing you're going to go for is in a clinical space and test it on patients. That's not what I was alluding to. There are other ways of testing, and then you can figure out whether something's going to work or not. Where my experience, as well as my students, my innovation fellows, their experience of past failure is concerned, and those tend to be, let's say, design thinking frameworks. I don't know if people are very familiar over there with design thinking, but human-centered design thinking, which essentially your client, or the client could be a patient, could be a learner, could be a student, could be faculty, could be staff, doesn't matter, but you kind of empathize with them and you start the process over there as to, like earlier I mentioned gap analysis, or what's the need of your client. And so your prototype, whatever that may be, whether it's a process or something else, testing that within a framework so that your risks I'm not talking about clinical risks over there, by the way, right? So I'm talking about other kinds of implementation. So we've learned by implementing and then going back to the drawing board, and then that's how you get to the next iteration as well. So rapid prototyping testing is in cycles of iteration, if that makes sense. I'm also trained as a clinical researcher, right? So my mindset, clinical research mindset, which is based on clinical research questions, let's say, or hypotheses, that's a very different approach then. And that's my research approach versus an innovation approach. That's within the limited time, I think that's the best I can do in order to explain that. And I think we've got to have that conversation in which we unpack this further as to, what is that scenario that's being discussed? And then we can probably then figure out, okay, what is the risk that, or what's the failure that we're talking about?
Thank you, Dr. Mia. We have another question. And also, those on Zoom, if you have any questions, please feel free to unmute yourself or share it in the chat with us. Thank you.
Hello everyone. My name is Mohammed. I'm in the 2-year Masters of Epidemiology program. I'm also from Pakistan. My question is to anyone could take this, but specifically for Dr. Surajit Nandi. It's about when you go down this path of trying to use digital health solutions and solving something for in an LMIC setting, what are 2 or 3 of the biggest challenges that you've had to face in terms of implementing such a solution in a low resource setting? Just some 2 or 3 biggest challenges that you've had to face. I know one of the panelists mentioned about physicians having to use these technologies and changing those behaviors. But what other challenges have you guys faced? Thank you.
Oh, that's another long potential answer. Well, I'll tell you a short story. At one point, Raxa had an office in a place called Horse Village in Delhi. The name doesn't really matter. It overlooks a nice lake, a very old lake, a pond, and so everyone in our office would drink from water, and we needed a backup because in India the water in the taps is not potable, so we need to get water that's kind of brought in. And it was brought in these sealed Pepsi bottles. Pepsi has a brand called Bisleri, and these bottles are brought in. And then one day someone told me that that they had seen the guy who delivers the water take the bottle and put it and fill it up with a tap just down the street, and then put the seal back on it. And when I confronted him, he said no, he didn't do it. And at the time, I was giving him 100 rupees, which is, I guess it was $1.50 to him to pay in part payment for his water services. And he had his hand on that 100 rupee note, and I had one hand on the 100 rupee note. And I said, you do not, you can't give us water that, that is not safe, because we need to have safe water. And I found myself in a tug of war for 100 rupees or $1.50, and back and forth until the note tore. And I thought that this is a challenge that I had never been trained for in all my training to actually meet. So that's just one of the kind of examples. I think Dr. Latif and others have talked eloquently about the problem of a startup. So startups in the rest of the world, including, by the way, Europe, do not work in the way that startups in the US work. So in the US, a startup has a good chance or some chance of becoming a world-leading business, like Meta and Google. These are all examples of that. But if you were to ask yourself, how many technology products that you use were built outside the US? And for all of India's, I mean, I know a little bit about the Indian system. All of India's tech solutions. I've asked this question to many people, and there's one that I've heard of, which is called Zoho. And I don't know if many of you know about Zoho, but it is the case that most tech in the world comes out of startups that came out of the US ecosystem, and they do not come out generally out of the European ecosystem, and certainly not out of the LMIC system. So I think the second challenge that I would refer to is the idea that if we have the idea that things are going to start up and go, especially in a field that is very slow to take off and very slow to adopt, and that I tried to show earlier, like healthcare, the ecosystem for a startup has to be accounted for, and those ecosystems do not lend themselves to fast growth in the way that we think of US startups growing. So I'll stick to those two, but I think if you'd like to contact me, please feel free to get my email from the organizers. I'm happy to delude you with all the other challenges as well. Thanks.
Very kind, Dr. Nandi. Thank you so much. If anybody else from the panel also has something to add, please feel free. Otherwise, we have another question ready for you.
Can you hear me now?
Yes, we can.
So thank you so much for all of your insight today. My career in advance of this was working in digital health with some technologies across Canada in the cardiovascular space. And one of the things I found I really struggled with was the scale up of technology in the sense of, you know, disseminating and deploying technology on a large scale, but at the same time balancing that change management, moving from historical means of processes to new means with digital health. And a lot of the time there were a lot of struggles when we looked at patient safety, patient security, when, for example, the digital health technologies didn't work. So I was wondering if you could speak a little bit to how you balance scale up of technology with that change management piece of, you know, having an innovative technology that people are unfamiliar with, and how you balance those two in between.
Perhaps Dr. Ford or Dr. Latif could go ahead.
Sure, I'll be very brief. It is a big challenge, and this is one of the things that we had to realize is that this is a years-long process. You know, and it's really a chicken and egg thing. So we actually pushed out our first telehealth technology sort of across our entire agency a dozen years ago. Maybe more, maybe 15 years ago. The big Polycom units, the big carts with the camera on top. We bought one for every site in the country that we had, about 500 of them. And what would happen, we go around, they would be in a closet collecting dust, right? So we had the technology, but not the change that you're talking about in place. So that has slowly come now where people are realizing the value and changing their behaviors, but it is really hard. The way we would try to do this is engage a champion at that site and then have them help us move forward. But echoing what was said earlier, the biggest change for us was the pandemic. Telehealth accounted for less than 1% of our visits across our entire system, across the entire nation. During the peak of the pandemic, it was over 40%. I think we peaked about 42% of all of our patient contacts were telehealth. So that was a huge shift for us. Now we've dropped back down, but we're still well above that less than 1% that we were. One of the biggest shifts and I think that this has been very helpful for us, at least here in the US, is that now it's become consumer driven. Our patients are asking for telehealth. They don't want to drive 3 hours for a 20-minute psychiatry visit, right? They want to be able to connect from their home or from a different setting. And so now that it's become patient/consumer driven, I think we will see that continue to snowball, at least here in the US. Thanks.
Thank you so much for all the perspectives.
So I'm actually gonna. Oh,
okay,
sorry.
yeah, sure. We are almost on time, so if you could have a brief answer. There's also a class that's scheduled here, so that's
Sure.
sorry about that.
I would actually echo what Dr. Four has said, and I think there are lessons to be learned from other aspects of healthcare. So quality improvement is one, which has really been about getting people to adopt new approaches to doing things, right? In this case, talk about technology, but changing people's behavior is probably very hard. And luckily, I think over the last few years, last 5-10 years, we've had an increasing focus on things such as implementation research. And I think the same principles apply to telehealth. And when you look at implementation research, there's lots of models out there, but basically there's 4 or 5 main domains that you have to look at that have to kind of balance out to make things happen, to make change happen. There's things, the outer domain, the greater ecosystem of the world, what's happening. It can be when you look at the outer domain, it can be outside of where you're immediately working, right? Which can be a unit, which can be a hospital, which can be outside in your country, but things that are outside your control often. And that's, I think, something that COVID really provided to everybody around the world globally, and outer domain, which is conducive to using digital health. The inner domain of often focuses on ourselves. Do we want to have the change? Do we accept it? And this is where we often fail, because people's acceptance of technology and acceptance of change is really the biggest limiting factor. Then there's things often related to the process itself. Is it easy? Is it user-friendly? Is it helpful or not? Is it something that we can adopt and adapt? And then there's things like the innovation itself. Is it something you can work on? Is it peer pressure? And actually, that is probably one of the biggest motivators for change, peer pressure, that we found not only in healthcare, so the area where we're quality improvement. Turns out when we did individual quality improvement projects in specific units, they worked while we were doing it and then fell off the face of the map and went back down to zero, all improvements, when we stopped. But when we do it at a collaborative level, at 100 unit level, that actually lasted a lot more, because then you're kind of in competition with everybody else. So there's many areas to work on. And I think once in a while, the perfect storm kind of happens, which allows adoption of these things. And we just have to capitalize on it.
Thank you so much. Thank you to Dr. Mia, Dr. Nandi, Dr. Four, and Dr. Latif for joining us. And thank you, everyone. We'll start our next session. Please reach out to the organizers for the next venue. Thank you.
Thank you.